Okay, well, thank you very much. Welcome everyone to this technical assistance webinar. It is on for the RFA MH 24-120 precision mental health, develop tools to inform treatment selection in depression, the UH3 Clinical Trial Optional. And we are delighted to have you here. As a general information, as Dr. King already mentioned, this call is being recorded. The recording of the meeting and the content of the presentation will be posted online at a later date. If you have questions, please submit them via the Zoom chat, and Dr. King will monitor the Zoom chat, and we will try to get to them at the end of the presentation, after the presentation. I know that we also have additional NIMH staff on the technical assistance webinar today, so they will hopefully be able to help us if there are some specific questions. So first, I would like to go over a little bit about the notice of funding opportunity NOFO. For some of you, you will be familiar probably with the term funding opportunity announcement, FOA. NOFO is the term that has replaced FOA, so you will hear us refer to NOFO. You may also hear me refer to RFA, which is a request for application, and that is a type of NOFO, just so for avoid some confusion here during the presentation. The NOFO that we are talking about is the Precision Mental Health Developed Tools to Inform Treatment Selection in Depression. This is a phased award that requires the completion of milestones in order to progress from the first phase, the UG3, to the second phase, the UH3. And to note for everyone is that this is a cooperative agreement. And that means that in difference from kind of regular parent research grants, there is a substantial involvement from NIMH staff, as well as implementing a steering committee to guide the project. The purpose of this webinar is to provide information about the NOFO and answer general questions. Please note that we cannot provide feedback about specific planned applications or research projects that you have in mind. If you want to discuss specific applications or aims or the applicability to this for this NOFO, please contact me. You can send me an email at me.hillerfors@nih.gov. I am also listed at the research scientific research contact in the NOFO, so you will find my information contact there. As a background to the NOFO, there are several treatment options for depression, as we know. These include drugs, medications, psychosocial interventions, digital therapeutics, brain stimulation methods, etc. However, we also know that the selecting the right treatment still relies largely on trial and error. Each treatment may require 3 months or more to determine if it's efficacious for a specific individual. And about 40% of the patients that we treat do not fully recover, even after a year of treatment with one or more of available antidepressant treatments. There is an urgent need for tools that can integrate the pre-treatment measures to predict whether a depressed individual will have a differential therapeutic response to a specific treatment and can help aid clinicians in selecting among the multiple available treatments. The one goal of this NOFO is to create a pipeline to support initial tests of validation and feasibility of objective, easy to use, and widely accessible tools for predicting response to depression treatments at the level of the individual. So we are really looking at something where the clinician can use to make a treatment selection for an individual patient. And looking at it, it can really look from social environmental determinants, and going down to biomarker tools, digital assessments, and patient in the loop, continuous learning, and being able to stratify patients for treatment response. So specific to this NOFO, we want to mention about the phased award mechanism, the UG3 UH3. So the U stands for the cooperative agreements, the two different phases. You may be familiar with phased awards in other NIMH and NIH funding opportunities. For example, our clinical trials pipeline, they use the R61 or R33 phased award. So for this NOFO, the total project duration cannot be more than 5 years. And the UG3 phase is between 1 to 2 years. So it cannot exceed 2 years. We do not specify the length of the UH3, but together the two phases cannot exceed 5 years. We NIMH intend to issue about 10 awards in 2024, and it will be used with set aside by the NIMH. We have limited the budget, so the phase 1 UG3 phase is limited to $500,000 in direct cost per year, and the UH3, the larger prospective clinical trials, are limited up to $1.5 million in direct cost per year. The timeline for this phased award is, as I said, up to 5 years. The phase 1, which is really preliminary studies looking at, for example, retrospective secondary analysis, fast phase pilot studies. The goal is to de-risk efficacy trials by demonstrating sufficient signal for clinical utility. And we will be using kind of rigor, reproducibility, generalizability, and evaluate those as go-no-go criteria. The phase 2, the second phase, the UH3, is a larger scale biomarker tool stratified clinical trial. So prospective trial to test the efficacy of the biomarker or the tool that is being proposed against standard of care decision making. And the goal is really to be able to select between at least 2 antidepressant treatments. I will add the important thing is that this NOFO is not about developing the interventions themselves. It is really about the biomarker, the tool biosignature, and we are looking at the already well-established treatments, and we'll be coming to that as a question. Future plans of this NOFO, which is not part of this initiative, which is not part of the NOFO, is that once we have it established and identified biomarkers or tools, we are hoping that we would maybe be able to establish a point-of-care technology research network to support rapid development or commercialization and implementation in the real-world conditions. That is not something that we currently have allocated money for, and it's something that is more aspirational rather than that we know will happen. But I wanted to mention where are we going past this, the current NOFO. The timeline for the FY24 specifically is there is a letter of intent due September 18th this year, 2023. Letter of intents are optional, they are not required, but it is very helpful to the NIMH for planning purpose, both to understand the workload as well as for review planning. So we welcome if applicants send us a letter of intent, but it is not required. More information is in the NOFO. The key dates to keep in mind: the NOFO is currently written for 2 cycles, one in 2023 and one for 2024. Currently, we have set aside for 2023 or the first round. The second round will be depending on available funds. So we don't, but it is the data and key dates are listed in the NOFO. The important thing is that the due date for applications is October 18th, 2023, this fall. We anticipate that the scientific merit review will take place in March 2024. It will go to the NIMH Advisory Council for review on the May Council 2024, and the earliest start date would be next summer. That is all in the best case scenario. So that is really the quick overview of the NOFO. We have already received many questions, so we wanted to reassemble a lot of general questions that we have. We thought we will start by going over them, and then we'll be happy to take more questions and try to answer them to our best ability. And Dr. King will, as I said, monitoring the Zoom chat box to see what questions we're getting. But please, you may want to hold off to see if we already have answered some of them in our following slides here. So one question that is, will the RFA be reissued or submission dates added? And we are, at this point, we are not planning to reissue the RFA. They have the 2 submission dates. We are not planning on adding additional, and I would say that the second submission date will depend on available funds. What are the budget caps? We, as listed, the maximum annual direct cost for the UH3 phase are $500,000, and for the maximum annual direct cost for the UH3 phase, the second phase, is $1.5 million. Can prior approval be obtained to exceed the budget caps? Short and correct answer is no. Are the set-aside amounts that are provided in RFA for the full duration of the grant or only for the first year? So we are, the set-asides are for the first year of the grant, and we are, NIMH intends to commit $5 million total in FY 2024 to fund up to 10 awards. Are there special page limits for applications under these NOFOs? And the answer is no. Standard page limits apply, and the research strategy section is limited to 12 pages. You can find information on the web about how to apply for page limitations or page limits. Are applications from non-US institutions allowable? And the answer is yes. Foreign institutions are eligible to apply. You can find more information about that in the section 3 under the information about eligible applicants. Are appendices allowed? We are following the NIH policy regarding appendices. You can find that information in the notice OD 17098. Specifically, only these appendices are permitted. You can have blank data collection forms, blank survey forms, blank questionnaire forms, simple list of interview questions, and blank informed consent assent forms. Please note that the letter of support are not considered an appendix and can be submitted as a part of the application. Will applications be assessed for responsiveness before being reviewed, and what are the responsiveness criteria? And yes, all applications will be assessed for responsiveness prior to peer review. So this is part of, as this is a request for application, an RFA, and there are very specific criteria outlined in the NOFO for what would be considered non-responsive. I would really advise all applicants or anyone who is considering putting together an application and under this RFA to read those in the bullets. We have copied them here. I will not read them all, but they're all outlined in the NOFO. Because if your application meet any of these criteria of non-responsive, the application will be withdrawn from and administratively withdrawn by NIMH prior to review, and it will not go to peer review. So this is not a case that we never like to do that, but we want to make sure that all applications are responsive to the NOFO before sending them to peer review. So this is really a look at part 2, section 1 about what would be non-responsive criteria. Is it allowable to propose a clinical trial? Yes, it's optional. It is allowable but not required. We will accept applications that propose studies that meet the definition of a clinical trial if the prospective assignment to intervention and assessment of outcomes serve the purpose of deriving or validating a biomarker or signature that can accurately predict depression treatment response. The trials focus on determination of efficacy and development of candidate therapeutics as their primary goal, are not considered responsive to the NOFO and will not be reviewed. As I mentioned, the goal is really to look at the biomarker tool signature or biomarker, but not at the developing the intervention themselves. You can find more information about NIH definition of clinical trial and NIMH funding of clinical trials on our websites. What is considered well-established treatment? So for the purpose of this NOFO, well-established treatments for depression is defined as those that are FDA approved, which for drugs and devices, or for non-regulated interventions such as the various psychosocial or cognitive behavior therapies that were considered well-validated, widely used, and recommended for treatment in treatment guidelines. I would say that we are talking really about evidence-based interventions that have shown efficacy. What are the expectations for data sharing for this NOFO? The same as what NIMH requires for all projects that we are funded under in this NOFO, that they will deposit biannually all data generated by the project into the NIMH data archive, also known as NDA. You can find more information about the NIMH data sharing on this web link. And as I said, we will be sharing these slides afterwards, so you can have all the links through the slide. There is also many references in the NOFO to the NIMH data archive. So if you're not familiar with it, I really recommend that you check out the NIMH data sharing policy. What type of expertise is optimal for a study team? We are expecting that they will be multidisciplinary teams that should cover the expertise in areas relevant to the proposed project. This can be include, but is not limited to, biomarker and signature development, clinical expertise relevant for the clinical populations of interest, including clinical trial designs, computational, statistical, bioinformatics analysis, experience with use and development of detection method technology, biosamples, data, tissue source standardization, biological, behavioral, physiological expertise in depression condition or conditions under investigation. So a broad range of expertise. It really needs to be relevant to the project that you are proposing and cover all the areas that are needed in order to conduct a project. Importantly, we are expecting we are requiring multiple principal investigators, MPIs, for the projects, and that all MPIs should be involved in the development of the research plan and the coordination and execution of the project. We anticipate that that all the PI should be part of writing the application and kind of not just jumping in at the end and providing a short section or something. It needs to be a whole picture where the whole team is a part of the process. This is essential in order for the projects as they go forward and being conducted for successful projects. So those are what very general, some of the general questions that we have received leading up to this technical assistance webinar. We are certainly we are happy to take more questions now in the chat. If you have questions after the webinar, or you feel we want to follow up on more on any of these questions, please feel free to email myself at me.hillerfors@nih.gov or Dr. Erin King at erin.king2@nih.gov, and we will be happy to get back to you and try to answer the question to our best ability.
Me, we have a few questions in the chat if you want me to go ahead and read those.
I probably could stop sharing here and we'll move to the see. So yes, please go ahead.
Sure. So the first question is, how do we handle indirect costs of funds allocated to the multiple PI sites?
Well, so the budget, we are looking at the applicant in the institution. So there's even if you have subcontracts, that would be for the applicant institution to deal with, and ultimately we are looking at what would be the indirect cost in the budget that submitted to the NIMH.
That was my question. That was my question, me. And the problem, I already discussed it with our grants office here. So if we have just for example, I got on board very quickly with the multiple PI and have arranged, we got 4 institutions prepared to work on this together with complementary expertise. So if we have, for example, $100,000 budget at one of the institutions, and we have to take out of, and let's say my institution is the host one who gets the $500,000 grant, we have to pay the $100,000 out of our $500,000 direct to the subcontract at one of our sites and pay $67,000 more for their indirect costs out of our direct cost. And that doesn't seem to be the intent of a $500,000 direct budget cost. So we'd end up paying, if we have 3 institutions, we'll pay $200,000 of that in indirect costs, and really only had $300,000 for direct costs. There used to be a mechanism of multiple linked RO1s. They came in as a project together, and then each of them would have just, the indirects would have been separate.
Yeah, this is not so this is a very good question, and I will cite 2 answers. One is that no, this is not a collaborative R1, so that doesn't limit, and it becomes one budget. I would, for specific questions, I would advise you to contact the Terry Yarosik, who is listed as the financial grants management contact in the NOFO, and Erin, maybe you can put in the chat her, actually I can put her information in there. So Terry Yarosik, she, for direct financial and budget questions, I would advise you that you could ask her about that. But otherwise, there are no, yes, the circumstances usually would be addressed with collaborative R1s are not part of it.
So because we are planning the phase 1 and phase 2 together, obviously. I mean, that's what we had thought. So I wanted everybody to be involved from the get-go so that we put together our plan together. It's possible with a $1.5 million budget, but with $500,000, as I said, 40% of it will go to a second out of the direct costs will go to indirects for the collaborators. Correct?
I cannot answer that question, but I do understand. I do understand what you're coming from, and my advice is that it depends on what your project will be, your budget, and what sites. And if you have direct questions, I do see that Nick Gayano, who is the head of the review branch, had his hand up.
Thanks, me. So this is really the purview of grants management. And Perry's in the office next to me, although she's not here right now. But this came up recently, and I absolutely encourage you to confirm that I have this straight. But we recently saw some things that looked like they were over the budget cap, but it turns out that consortium indirect costs, I do not believe count against the budget cap listed in the NOFO. And it's for very much the reasons you're describing. It seems like it would be sort of nonsensical and a penalty to the investigators. So yeah, please, of course, double check. I wouldn't march off and assume that's correct, but I'm 95% sure that that's correct.
Very encouraging. Thanks.
Okay. Thank you, Nick. That's very helpful. And yes, please contact Terry Yarzik, who is the head of our grants management branch.
So we have a few more questions in the chat. The next one is, would the PI be able to maintain ESI status if receiving the UG3 UH3 grant?
So I will have to check on that. I know. Okay, Nick.
Yeah, I saw that question in the chat and I looked it up. I think the answer is no. It's a substantial enough award. So there's a list. You can go look online. There's a huge list, and they tend to be smaller awards of what you can get and retain ESI status. But UG3, that's not on there. It tends to relate to what the size of the award is, as far as whether that gets rid of ESI status or not.
And it is also, so I would say that the size and the intention of this is certainly larger than many other ones. So it's really is. The application itself will most likely not receive an ESI status because we are asking for multi-PIs. Unless all PIs are ESIs, the application does not get the ESI status. So it's not. So it's something to discuss. But we certainly would like to see earlier stage investigators or more junior investigators involved in the projects, because we really like to have the diversity and the range of the investigator pool.
Great. The next question is, can phase 1 projects be 18 months or do they have to be 12 or 24 months?
They can be at maximum 2 years. It is up to the applicant to decide how you want to divide up the 5 years, with the first phase not being more than 2 years.
The next question is, are EMA symptom assessments with or without physiological measures considered signatures for prediction?
I cannot answer that question. It really would depend on what you are, kind of how it's put together. And so it's, I don't have the answer for that.
Sure. So in addition to testing.
We are happy, however, for whoever put in that question, if you want to have more, we can certainly set up a time, talk more once you have your aims and what it is, and have a more in-depth discussion with the NIMH subject matter experts to see if it is a good fit for the RFA.
Sorry about that, Me. In addition to testing univariate predictors of differential response, is it considered fair game to use machine learning to generate precision treatment rules to predict the optimal intervention for a given treatment?
So we are looking at a broad range of tools. It can be biomarkers, and I think we have listed a lot of the different, whether it's imaging or computational, if it's blood-based markers, clinical markers for being able to ultimately help a clinician making a selection between at least 2 antidepressant treatments. So it really depends on how you are planning on using the proposed algorithm as a biomarker.
Okay, another question asking if primary care and secondary care are both allowable, especially if they include the source as a variable in the prediction equations.
I am not sure I really understood that question between primary care and secondary care here. So could you read?
Yeah, that would be me, Steve Holland. And secondary care, most folks are seeking treatment. Primary care folks are not necessarily seeking treatment, but they may happen to be depressed. And there's emerging evidence that most folks who are depressed don't seek treatment. And so you may have different biomarkers, different prediction equations for those two different settings.
It will be up to the applicant to decide in what population, what setting, what is the most likelihood that your biomarker would be of utility to a clinician. So
Gotcha.
it's and it might also depending on what fits to what type of studies that you can do and run and conduct under this NOFO.
Okay, it looks like there's the last question in the chat is someone mentioning that they have strong preliminary results and they're trying to decide whether to finish up analyses and write up for publication. And if the publication submission would strengthen the application for this NOFO, or if the spirit of the award is such that this wouldn't strengthen the application.
That is not something I could answer. I think it depends on what you believe you need to do to make the case for the biomarker for the tool and why the rationale for studying and validating, assessing the tool in a study here. So it's I cannot answer whether to publish or not publish or whether it will strengthen or not strengthen your an application.
I don't see any additional questions in the chat unless I'm missing any. If anyone else has questions, feel free to unmute and ask them.
Well, yes, I do see Dr. Listenby.
Hi, thank you for the presentation, Mee. I want to go back to a few of the prior questions. First of all, about machine learning. Absolutely, we expect innovation in terms of data science approaches. And so if that is relevant in terms of your prediction algorithm, we absolutely are looking for innovative data science approaches that might include AI, ML, et cetera. Regarding the question about publishing, I mean, this is going to peer review. And think like your peer reviewers, the more evidence that your findings have passed peer review may be influential in terms of understanding the quality of the project that you're proposing.
Thank you. For those of you who may not be familiar, Dr. Listenby is the director of the Division of Translational Research and really has been the initiator of this NOFO, so you have the best information possible here. I would like, just as an end, before I don't hear the question, is really recommend that you read the NOFO very carefully. There's a lot of information in it. There's also really specific, I would recommend for applicants to read the section 5, the instructions for 2 reviewers, because that has a lot of information. What we will be asking your peers to evaluate and assess when they review the applications. And if that information is not part of your application, reviewers will not be able to evaluate it. So you can receive a lot of information there in what you should include in an application. So that is my kind of advice to all potential applicants or interested parties. We are happy to answer more questions after. If you want to have more input on once you decided to that you want to apply and you have aims, we are happy to find time to give more input or guidance on the NOFO and the process, as well as input on your aims if that is appropriate or as appropriate. Well, I do not see any more questions, Erin. And with that, I want to thank, first of all, I'd like to thank Dr. Erin King for setting up the technical webinar and for preparing everything for today and for her work on the NOFO. I also want to thank both Dr. Nikayano and Dr. Holly Lisenby for helping answering the questions today. And I wish everyone good luck.
Thank you, Ming.